these in Medicaid updates. If you aren't subscribed to those, I highly recommend that you subscribe to the Medicaid update newsletters for more information. And I can either put links to those for more detail in the chat if that's okay with this group, or Jennifer, I could email you with links to all those appropriate Medicaid updates and the contact information if you distribute anything to the group that way. Happy to do whatever is helpful for everybody.
Yeah, I think that'd be great, Casey. If you could send me those links, I'll make sure that it gets out in the notes so everybody has access to it. I know it's some really great information, but maybe retaining in real time is a little tough with all the details. Yeah.
Okay,
great.
I will do that. Thank you very much, everybody.
Thank you. So we don't have any other updates from any other state agencies at this time. So I did just want to give a quick AHI update. So many of you may realize, and this is just kind of adjacent to the work that this group is doing, AHI did submit a application for Connect All for the technical assistance funding, and we were awarded that funding. So we're going to continue our work with Fort Drum Regional Health Planning Organization on some of the background work on that, but we're excited to announce that we're going to be relaunching the North Country Digital Inclusion Coalition. So more to come on that, but I did want to just give folks an update on where we are with that. And then if I seem slightly frazzled today, it's because we are submitting our Connect All Digital Equity grant, and that is due today. So I'm just waiting for a final sign off, and we'll be submitting that today as well. But we will be participating and working in conjunction with our partners at Fort Drum Regional Health Plan Organization. And really the goal is to ensure that there's capacity with our providers, our coalition partners, and getting digital devices into the community, doing appropriate training on anything from cybersecurity, on digital equity, or how to use your device. So we're really excited to put forth that plan, and hopefully more to come if and when we are awarded. We'll let you know that, but I did want to just give some of that quick updates on that as well today. I'm going to turn it over to Dr. Dinkels in just a moment, but you will see below we have some news articles, research, entities, and then I did just want to plug a couple of events that are coming up. And then for those of you who are local, AHI is hosting a Connecting for Success event on May 16th at the Courtyard by Marriott in Lake George. So that link should be in there if you want to go ahead and register if you're interested, but feel free to contact me with any questions that you may have. So I am going to introduce Dr. Michael Dinkels, and he will give our presentation today titled Bringing It All Back Home. And then he'll be available for questions afterwards, and I'll send out his slide deck and this recording as well when we're done. All right, Dr. Dinkels, I'm going to pass it over to you.
Yeah, thanks. First, just want to make sure the audio quality is okay.
Yes, he's great.
All right, perfect. Thank you. Yeah, so Dr. Dinkels, Mike Dinkels, I'm a pulmonary and critical care specialist. I've been working in bedside intensive care units in New York since I got out of training about 15 years ago. So I do a lot of telemedicine work now, and this is obviously a telemedicine and focused talk because that's what I do. So the title is called Bringing It All Back Home. The talk's going to focus, it's a clinical talk for the most part. It's going to focus on what I think are the factors keeping people from staying home and some of the things we can do to keep them home, some new ideas, some new models. Yeah, so just to jump right in. So I think the next is just, yep, that's us. That's today. Here we are. Okay, my disclosures. So I'm a founder and an owner of a telemedicine practice. It's based out of Albany. Critical Care Telemedicine PLLC. That's the group. I founded it in 2018. At this point, we cover 6 hospitals. We had 8 hospitals at one point during COVID, but we got 6 pretty good programs going. 5 of them are in New York State. I do have professional service agreements with these different facilities. I do not have ownership in anything else besides this practice. The presentation today, it's a clinical talk. And for the most part, it's going to represent my opinion, basically anecdotal opinion from my bedside experience and what I call my video side experience for 20 plus years since being a doctor. I can assure you my video side experience has led me to see many more patients because of how efficient it is than I ever did when I was at the bedside. So this all comes together to form my ICU sort of opinion on what's happening to these folks once they leave. Just one last disclosure. I did use an AI tool just to help make some cartoon images for this presentation, not all of them, but some of the pictures just to get the ideas out of my head and just to express them a little better. I did use an AI tool. So I'm ICU trained, I'm pulmonary trained. I went to med school down in Philly. Ever since then, I was back in New York. I went to residency and fellowship were both in the city where I was born and bred. Fast forward a whole bunch. After working down in Putnam County for a little bit, I came up to Albany. And for a little while before COVID, I was a director of the ICU at St. Peter's here in Albany. When I founded the telemedicine practice separate from that other work, I did pull back, and now I focus on the telemedicine practice all the time pretty much. I do bedside work still. I'm mostly up at Glens Falls Hospital with a few colleagues of mine back from the St. Peter's days. And finally, I am an enthusiastic reader of fiction and a watcher of film, and some of the film will be coming into this talk today. All right, just quick summary. I believe this whole concept, this whole talk is a discussion of wellness. And this is how I'm going to define it for this purpose. Wellness means to me comfort, and comfort could be physical, emotional, social. I think a lot of us forget when they're in the ICU, and I think when you're in the clinic setting, a lot of us forget that comfort is a spiritual thing too, and comfort is an environmental thing, meaning the home, the trip to the office, the hospital, etc. Wellness, in my point of view, is lost when people have critical illness, or you could even call it complex illness at this point. Most of them aren't even getting into the ICU, but they're still complexly, critically sick. Wellness will stay lost if their complex acute illness turns into a sort of complex chronic, I call it a disability, but just complex symptoms, chronic symptoms, I should say. The wellness loss can be amplified. I truly believe there's a lack of trust and a lack of presence that, presence and trust get lost as patients and providers and the rest of the team, we all get shuffled from one location to the other. The system, right? The lack of trust in the system obviously is prevalent. I just want to point out that wellness loss can occur either in the ICU or on the regular wards. And recovery of disease obviously does not mean return to wellness. And of course, there's a lot of reasons for this. I consider some of them to be excuses for it, not just reasons. And I'm gonna claim that a new paradigm can emerge, that with new language and new discussions, I feel this return from the journey from wellness to being sick and the despair of acute sickness, and then back to wellness, I think it can be obtained, and I think it can be for all, ideally, in the perfect situation. So the summary, the objectives that are going to be next. So 3 objectives. First, I just want to explore this concept of telepresence, and I'm just going to point out through some pictures that telehealth, telemedicine, but then telepresence may not all be the same thing. I believe in telepresence, right? I believe that the machine and the video can be an extension of an interaction more than anything else. Obviously, it's not easy to achieve, but that is the ideal. Because if you can be present in the patient's home or the community member's home, that's their arena. That's their area of high wellness, right? And we need to cut through the barriers. In the second objective, we'll talk about the barriers from my point of view that keeps people out of their home and stuck in the hospital. And that's an area of low wellness. And then I'm going to create some new language and talk about some new practice models that maybe can help keep folks back in their home. Okay. So this quote, "Into whatsoever houses I enter, I will enter to help the sick." Okay, so that quote, it's from the Hippocratic Oath, right? It's an oath I took, right? All providers take it. So that oath specifically talks about the patient's home. And it says, into whatsoever house I enter, I'll enter to help. So obviously over many centuries, that's meant many different things, but the oath has not changed. And the fact that the ideal physician and the ideal location would be in the patient's house where they're most comfortable and they have their loved ones and they feel most safe. Right? So a picture, right? This is a good example. Just centuries ago, guy comes on horseback, visits a patient. Clearly, he's going to be present. There's no phone. There's no pager, right? He's there for hours probably. He's present in the moment. Next picture will show the same thing. A little different, right? But you could argue that this doc is still present, right? Patient's family present. Patient scared, but he's comfortable. Next pic, same thing. The Don, Vito Corleone, right? He's present. There's his son in the background, Fredo. He's getting his pneumonia treatment. I don't know what they're doing, some sort of candle melting or whatever on his chest because he has pneumonia. But just keep in mind, this is in the home. That's where it started. That's where ideally it should be. Next, we could show that, you fast forward a little bit. Not all care can occur in the home, right? Here's a busy clinic. It's starting to get a little crazy. Patients are scared, right? Not everybody's comfortable. The doc and the nurse, as you can see, are in a separate room in the back. A little bit of separation occurring, right? Go to the next pic. This is sort of my take, right? What a modern clinic looks like from personal experience. This is what a clinic could look like, right? On the left side of the screen, that's a provider clinic. And on the right side of the screen, you have a DMV. And I'm wondering, who could tell the difference at this point? They look very similar to me. Sadly, no one's happy to be sitting in that waiting room at either place. So finally, obviously, you have the hospital, right? That's where I work. I work in a hospital. Here we go. The Don is now sick. He's in the hospital. His son's at his bedside. And he's not happy. He's not feeling comfortable. There's no one there with him. He's got a visitor coming. Sterile, cold, right? It's not ideal, but this is, for now, this is whatsoever house, right? This is his home while he's sick. But we never talk about what happens after the hospital. Well, we do, but what does it really look like, right? So this is my concept on the next slide. What does it really look like, right? So don't forget, they get discharged. And we always insist that the patient must be compliant and stay within the program and within the system. And we have so many systems in place and methods and services in place to get them where they need to go. But from my point of view, the complexity of how to get them there doesn't matter. They're just miserable getting there. And what happens to them? They get into the provider's office, and you have a provider who can't even stop to take the time to remain present with this person. This is an example of a person. He's out of the hospital. He was in the ICU. Here he is. He's better, but he's not better. And the stuff that gets lost between the cracks is stuff that his provider just doesn't have the language to deal with. So not present, not comfortable, not really ideal. Going to the next, this probably would be more ideal. The Don, Vito Corleone is back home. Not everyone is as lucky as him to afford having resources in his home to recover. But man, it would be nice if we can all get back home like he did. So what would it look like for us at this point? Well, just some examples. Telemedicine, right? You can't get the doctor back to the house. Well, now we talk about having the provider over video back at the house. And obviously this isn't new. Look at that article from 100 years ago showing a doc on the screen. And these other few pictures show nice, happy people at home. A provider's on screen. Everyone looks great. Obviously, it's not as ideal as this. The machines are clunky. Laptops and tablets aren't perfect. The technology is sometimes a little confusing for certain folks. But yeah, this would be ideal, wouldn't it? Just to have comfort in your own home with someone who's present and not distracted, connecting with you. So that's what I think it can look like. Just very quickly, I want to tell just a story about what sold me on this. This was, pre-COVID, well before I started doing this work. Just a little tidbit. So I was working in the ICU at St. Pete's. There was a patient. He was lying in the bed and he was doing a video call with his daughter, I believe. I came in to, I don't remember why, I had to look at him or examine him or what have you. And I sort of caught the conversation. I went up to his bedside, looked at him, looked at the daughter on the screen. It was just the two of them. And you know what? I just joined the conversation. And we ended up having a pretty deep talk. And it was an end of life talk, advanced goals of care discussion. And we sat there for a while. It was quiet. He was in a quiet room. I shut the door. His daughter was at home. It was quiet there. And the fact that she was on video didn't matter to me. We had a really deep talk. All three of us were present. And that's what sold me that this could be something that could really happen. And it does happen, obviously. I'll give an example on the next slide of one direction that it is. And this is obviously telemedicine here, and this is ICU telemedicine. But keep in mind, this, from my point of view, this isn't presence. This isn't telepresence. This is just, large unit, many patients, lots of different systems running at the same time. Telemedicine, definitely necessary, but not telepresence per se. This one I find funny. This isn't telepresence either. You have a patient who's you can't even see the patient. You have a nurse, you have, I think, a student and an intern and an attending talking. I bet you not a single one of them is really present in the moment. But with that said, that's still telemedicine right there. But my take of telepresence, obviously, again, the pictures I showed earlier, just to show, on the next slide, I'll show them again. These folks are present. Obviously, it doesn't need to be this fancy, but this is what I mean when I'm talking about presence. And if you look at the next picture, this is what I view. Patient returns home from the ICU, and there she is. She's not perfectly well. Obviously, she's still stuck in bed, but she's home, and she's in a warm place, and she has her family. And the provider, let's pretend the provider on the screen is someone that took care of her in the hospital. And maybe her disease isn't gone, but we're trying to promote her a sense of wellness as much as we can. And we're keeping her where she needs to be. This is what I envision, right? When I think about these wellness programs and these telemedicine programs that we can use for patients after they're discharged. So that's my spiel about telepresence, right? So let me change gears. The next objective was to talk about barriers. So barriers to keeping people out of the hospital, barriers to keeping them, specifically after the ICU, right? So I'm just going to show a couple of examples of just articles showing that, obviously the literature is looking at this. Obviously, organizations look at this. Government, everyone's looking at this, right? There's countless articles. And no one's ignoring the problem. And as you can see here, mortality, right? Readmissions, right? Go to the next slide and it'll show a couple more things. Internal medicine specialty readmissions. What are the factors? What are the outcomes? Where in the healthcare system can we pinpoint all the holes that line up to create this problem of people landing back in the hospital? So on the next, I highlighted what one of the conclusions was. And again, there's countless articles, but I really like this one because it points out two things that I kind of laugh at. Conclusion number one, the causes of readmissions is multifactorial. Okay, so to me, what that means is there's too many things happening and it's going to be too hard to deal with, and my department can't be in charge of it. And we'll just keep plugging along, doing what we're doing, and that's all we can do. This is for people up the chain of command, not for me. And the other thing I highlighted, early follow-up should be advised. So when I see that, maybe I'm a little jaded, but when I see that, I think, well, it's the patient's issue, and it's their responsibility now, and they better get themselves to the clinic. So maybe I'm interpreting this a little too extreme, but I'm just trying to point it out that from the patient's perspective, for us to say, well, it's multifactorial and, they need to follow up. It sounds so simple, and we could check off our little mark on our to-do list and then we move on, and they're sitting there saying, well, what does that even mean? So I think I know what it means. I'm going to give an example of a patient. And this is why I think when we say it's multifactorial and they just need to follow up, what it really means is a little bit more. So let me show you the next slide, please. This gentleman is one of my favorite patients. He was discharged. Let's go through the whole narrative here. I'm going to go piece by piece like I do when people end up back in the hospital. And I scribbled my notes just like I do in the hospital. So this gentleman, who happens to look like my grandfather, he got discharged 2 weeks ago. He's been home for a couple of weeks. I think he was admitted for respiratory issues. He got better. They sent him home. He feels good. What does he do next? Well, he's home for 2 weeks. And unfortunately, he's been smoking for the last week. And unfortunately, he doesn't really remember who they told him to follow up with first. There's a couple of names. More importantly to him, though, is it doesn't matter. He's going to go visit his grandson. He's got a violin solo at school, and everything else is just going to wait. He's got some other stuff to do. And he said something interesting on the next slide to the folks in the emergency department. He said that he's annoyed. He said that he keeps getting phone calls from someone, they call himself the CPAP. And he doesn't know who this guy is. Is it a boat captain? He has no idea. He doesn't know CPAP is a respiratory device. He doesn't realize CPAP was the thing that was on his face every night during his hospital admission. He wasn't paying attention. But man, this CPAP keeps calling him. So he blocks the phone number because he decides he's not interested in going on a fishing trip anyway. So he just is happy to be home. So what does he do next? Well, actually, 1 second before we say what happens next, that slide, go to the next one again. These are the 4 things that literature tells us could happen to him next. If he were to get readmitted, which is likely, he's going to get readmitted either with a heart attack or a new exacerbation of his COPD, or of course he'll be in heart failure. And of course, just like everybody, we'll tell him that, oh yeah, you got pneumonia again. So let's see if that happens to him. Well, he does visit his daughter and his son-in-law, and he stays with them, and he gets to see his grandson have his violin solo. And then that night, he's lying on the pull-out couch, sleeping, and he has a very rough night. He finds it very hard to breathe. He decides that he's going to get ready to go back to the hospital. He's not a fool, right? So he gets dressed. He patiently waits by the front door on the couch, waiting for his daughter to wake up. He doesn't want to wake her. You know, she's got young kids. He wants her to get her rest. So she finally wakes up, and very early that morning, he tells her, you might as well call me that ambulance. I think I need to go. Nice person, not very insightful for this medical disease. And here he is. Now he's going back to the emergency room. So let's meet him in the ER. So what does the ER doc do? Well, he's ruling in for a possible heart attack, a possible acute MI. So what are we going to do? Let's diurese him, throw some Lasix at him. And what should we do next? Let's see. Well, next on the list, a COPD issue. Well, he smokes. He's got COPD. He's probably having an exacerbation. What should we do next? Let's see. Let's go to the next slide. Yeah, give him some prednisone and some bronchodilators. Put on some nebulizers. That'll fix that, right? Oh, what if he's in heart failure? All right, let me think this through. Let's put him on, let's add to the list. On the next slide, we'll put him on a little bit more Lasix. Okay. Oh, yeah, and by the way, he's got pneumonia. Well, does he really? You know what? Let's not take a chance. Throw him on an antibiotic anyway. Let's put him on some Levaquin. Okay, here he is, right? Is he better? Well, he looks better than when he showed up with the ambulance. He's been in the ER for a few hours. You know, maybe it's pneumonia. We added bronchitis. Oh, yeah, let's say that rash on his legs, yeah, that's probably just an infection too. Let's call it a cellulitis. That'll justify our use of the antibiotic. So we covered all our bases. We're not sure which one of these issues is really the issue, but he's labeled. That's it. He's got all 4 conditions on readmission. That's that. What's really happening? Well, he decompensated at home is that's obviously what happened. The tender loving care of being in an ICU and then being in the hospital kept him good. And then he goes home and he doesn't take care of himself and he decompensates. So did he really get 4 new diagnoses, or is he just unraveling a little bit? Well, as we'll see, it's not really going to matter because we're busy. So what else is there to do? Oh yeah, on the next slide, there was one more thing we had to put on our to-do list. We forgot that the nurse at the bedside, because he is going to the ICU now because he's quite ill. Um, uh, he asked for a little bit of Ativan because the patient's a little wiry and confused, and he's not tolerating the oxygen mask. So yeah, we're going to put him on a little bit of Ativan now too to keep him calm, not worrying that in a day or two he'll get more encephalopathic because of it, and forgetting that use of benzos and other items like that actually do contribute to delirium and PTSD after the fact when they get out of the hospital. But we don't have time for that right now. So instead, we're going to just do what the good nurse asked us to do. So he lands in the ICU. What happens to him then? Well, his pressure drops from all the Ativan we gave him, and we're going to give him some fluids, but not too much because he has heart failure. Well, at least we said he might have heart failure. Next to-do list is, oh boy, that blood pressure still remained low. Now he's stuck on Levophed. Getting to the point, he doesn't look good. So what do I want to do next? Well, maybe it's time to do advanced directive talks with him. So let's talk about DNR status with him. So I'll put that on my list too. That's not really the right way of doing it, but you know what? I better make sure I address this before it's too late because we're losing time with him. But oh boy, I forgot that it's really late. It's the middle of the night. I should call the family, but let's wait. I feel like 4 o'clock is a good time to wake them. It's only 2 o'clock now. I'll give them a couple more hours. We'll bother them then. And then finally, when it becomes 4 o'clock, oh boy, it's now 5 o'clock and 6 o'clock. I never called them. I better sign out to the day team. I got a staff meeting in a few minutes. So here he is. He's stuck in the ICU. He's back. He's been labeled with 4 diseases that he may or may not have, but that's his list. He got admitted with them. They may end up staying on his discharge diagnosis list. He will become a statistic. So what really happened to him? Well, it doesn't matter. One more thing I'm going to point out is the agenda for my 9 o'clock staff meeting. Man, they're going to be talking about readmissions and patient satisfaction. Everyone's complaining, and the nurses are not happy with us because we're not responding in time. And man, they're also telling us that our productivity model is changing and we need to be more productive. And man, oh man, this actually is an aside, not a joke, a true story. They were sending us patient comments, and one of the administrators forgot to delete the patient's names. And a whole crew of providers one day were able to see who said what about them. Man, that's hard to deal with. And we better just keep plugging along. And this gentleman now has these diagnoses. There's no time to figure out what's what at this point. So here we are. At least that's my jaded take on what possibly leads to people getting readmitted and what happens to them and how they get labeled and what diseases we say they have once they're back in the hospital. So what should we do about all this? Well, it is a confusing mess, isn't it? At least from my point of view. I'm calling it an issue of miscommunication. What I mean by that is not poorly designed systems, not poorly trained providers and other members of the care team. What I mean is that maybe the language we're using isn't just up to par with what actually is going on. That's actually a common, the topic in literature is without the right language to discuss something, the people can't discuss it and they can't rise. So, it's talk the right talk and we can make better connections, at least is the point that I'm trying to drive home here. So what is the talk? What is the name for what's really happening to him? I do want to switch gears just a little and focus on what I think is actually happening to a majority of these folks. And again, it doesn't have to be ICU only folks. People who end up in a hospital now are just sicker than they used to be, unless they would have never been put in the hospital because it's harder to get into a hospital. So there is a name for what these people are going through, and it's been coined back in the 1980s. It was called post-intensive care syndrome. And it's not a specific disease. It's just a collection, a syndrome of other problems that always seem to link together once people are critically ill. So they get better, their illness is better, but what they're stuck with is obviously a bunch of physical impairments and disabilities, functional disability. There's a lot of, there's a lot of cognitive impairment going on too. Stuff that a family member might say, grandma's just not the same ever since she caught COVID. That really took a hit, it did a number on her. Well, is that really all it is? Or can we, go a little further and look into her cognitive impairment? It's a mental health impairment also, specifically talking about PTSD, depression, anxiety. And it's a family issue. PICS family is actually a thing. And we sometimes don't have the bandwidth to address the family's disability from the critical illness. And, another just a little quick aside, everyone's got family members who've been very sick, some closer than the others. And, when that family member is a child and very critically ill for many, many weeks, and when that child recovers and the family just wants to move on for the sake of the other children and for everybody, that mental health aspect and that family aspect sometimes isn't addressed for decades. And even though, there's words for this, there's systems for this, but maybe just not enough people know about these systems. But getting back to the point, PICS will persist even after they get home. And PICS is more prevalent now than ever because, again, as we get better at medicine, we're keeping complex patients around, obviously, much longer, better mortality rates, less morbidity, but not perfect wellness, So PICS, right? So PICS clinics, right? This does exist. A PICS clinic is an outpatient place. Been around since the 80s, especially out in England. They started this with the objectives of promoting wellness, lessen the suffering that the patient has after the illness recovers, or even if the illness persists. Try to lessen their emotional duress, facilitate their spiritual well-being. These clinics address the persistent medical problems. They try to reintegrate the folks into society. And I'm going to coin a term. They help these ICU survivors shine through all these dark times and get them back to where they want to be. That's the ideal. That's the objective of these PICS clinics, right? So historically, the staffing, I just want to list what the PICS clinic staffing has always been in the past. So a lot of the PICS clinics originally were led by the critical care pulmonologist who saw the patient in the ICU, and the PICS clinic would be sort of added on to their outpatient pulmonary clinic. So they would have the pulmonologist, they'd have nurses, PT, OT, ideally they'd have therapists, case managers, etc. And they would do a lot of screening and a lot of questionnaires, specifically for these disabilities that are associated with PICS. They would ideally keep it all in-house, but more often than not, what would happen is they do these screenings, and the clinic would be nothing more than screen the patient, refer them to whoever else can handle the specific things we caught when screening, and then say, come back in a month and we'll reevaluate and redo the questionnaires and see if you score any better. So, I make it sound like I don't mean to sound that that's all it is, but essentially that's what they started with. And even if that was all they were doing at first, this works. People with just knowing they have PICS is such an empowering thing, apparently, that it would just move them on, get them through some of the darker times and get them back to where they want to be faster. PICS support groups even would crop up. It's good stuff. But I just want to show you a text message I sent to a colleague recently on my next slide. I just want to say, but here's the problem. So I sent this message to someone that I trust, someone that is very experienced and very good at critical care and is really good at heart. I texted her. I said, hey, I'm starting an outpatient telemed PICS clinic soon. And her reply was, what's PICS? And this was from an ICU doc that has been in practice for probably 40 years. And I told her, well, it's post-intensive care syndrome. And the reply was, oh, yeah, interesting. Good idea. So, it's sad, right? We do have the language. We can talk these new models, but yeah, there's still a lot of miscommunication, a lot of lack of communication. So what do we do? Well, let me switch gears a little bit and talk about what we can do about this, right? We define the problem. I gave my anecdotal opinion on what, the problem is that people bounce back. And I gave you my opinion on what's really causing the problem. Well, yeah, obviously it's a new disease, but I think it's also, like I was saying, it's just not the ability to put it all together and realize a lot of stuff that causes bounce back is actually preventable if you approach it through a PICS sort of clinic model. So I like the opportunity here. I told my friend, oh, I'm going to start a PICS clinic, and she had no idea what I was talking about. Well, that means this is a clean slate here. Why don't we take what's out there? Why don't we make some better dialogue? Let's do some cutting edge ideas. Let's do some research, evidence-based stuff and make, a sort of cutting edge, contemporary PICS model here, PICS clinic model. Let's get these people back home. Let me present now just a couple of ideas on how we can make their wellness as high as possible. So, very quickly. So my practice, I'm going to springboard off of what I've been doing. So my practice has been around since 2018. Like I was saying earlier, we got 5 hospitals in New York, 1 in North Carolina. We do critical care and pulmonary. We added infectious disease. We're adding at one of the hospitals in New York a critical care resource nurse service. We're really trying to cement what we're doing in the hospital, because I found that even within the hospital, it's not miscommunication. It's more of, obviously at smaller hospitals, it's lack of experience with the really, really sick ones, and just lack of experience on what to do to prevent badness after they leave. So the critical care nursing, the critical care resource nursing model, actually, I'm very excited about. I think it's going to really improve patient flow, from ER all the way out the door. So that's what we've been doing. Currently, what my priorities currently are is to continue the good presence in the ICU and on the hospital wards. And we're actually looking to expand the critical care nursing model to include a lot of educational support and a lot of real-time support for not even the patient, for patient and family, and even the bedside nursing staff at the same time. That's been a game changer at some of the places where we've started looking into this. But where do we want to go next? Well, I've decided that if we can get this really working as an inpatient, what could this intersection from inpatient to outpatient look like? So we got a lot of new models. We're going to focus on the complex medical patient. We're looking to first focus, we're going to start some outpatient work. We're going to start by focusing first on the patients that have been discharged once they get home, just like the classic PICS clinic would do. We're going to focus on taking the model of a PICS clinic a step further and try to make a model where we don't have to refer out, where we could keep it all in one house, one comprehensive service. We're going to take these ideas from PICS and we're going to expand it a little bit and make it not just for the PICS treatments, but also for any complex medical stuff that the patients have going on. And with the help of a colleague of mine, we've decided we're going to call it the Medical Integration and Transitional Care Consult Service. And we're going to offer this to patients once they're discharged and when they're back home, and hopefully keep them home. So the goals, I just want to specifically talk about the goals of this sort of, consult transitional care service. Again, keep them out of the hospital, reduce their morbidity, increase their wellness, or I should say their quality of life. Do some of the PICS stuff, meaning screening for neurocog impairment, screen for emotional and mental health illness. Do these things to help the patient, obviously, but also to reduce the burden on their primary care docs, who, of course, are doing all this, but perhaps don't have the right language or office structure to make it the priority. And it's also going to reduce the burden on the patients and their caregivers. It's going to help the families be empowered. It's going to increase their ability to help. And what we're going to focus for the medical side of things, I'll just list them briefly. Again, it's going to be obviously treating specific cardiopulmonary disease. Most of these complex folks have cardiac, pulmonary, renal chronic disorders. So yeah, we'll be treating the disability and disease associated with their illnesses. We'll treat the primary disease processes. We'll focus on, the PT/OT aspect of getting adaptive tools in their environment or altering their environment. We'll teach them how to adapt to a new lifestyle. And we're going to bring in emotional support and mental health professionals, and we're going to bring in spiritual professionals and leaders to be part of the service, to provide sort of a one-stop shop for these folks, to get all their medical and non-medical things addressed over telemedicine from their home. And the folks that we believe should be involved in this when we put this package together, on the next. So we believe taking from the PICS clinic model. Oh no, you could go back to the specialist team focus. You can just go back one slide, please. So we believe that, stealing from the PICS model, that, maybe I'm biased, but I believe the intensivist could be the quarterback for a lot of this. The outpatient intensivist, not able to replace a primary care physician, but able to just quarterback and look for the red flags that might be making the patient lean more and more towards possibly needing to go back to the emergency room. Oh yeah, go to the next one, please. One more. I do apologize. What do you have on the screen right now? I see slide showing medical management focus.
Nope, it's patient initial assessment. What's the how?
Oh, okay. Let me see if my screen should refresh or if it froze. Bear with me. I apologize. We're on patient initial assessment.
Correct.
Okay. Before I talk about that, okay, now it refreshed for me. Thank you. Before I talk about that, I just want to mention that we do want to pull in internal medicine providers. We're going to pull in mental health providers, OT, PT, nutritionists. For the medical side, we're going to pull in specialists such as pulmonologists, cardiologists, endocrinologists, and we're looking to get involvement from rehabilitation medicine specialists as well. So in this model, what would the patient see? How does it work? What's the how? So from within 2 weeks of being discharged from the hospital, from their home, they would be registered and they would have their first assessment with our service, our clinic. And the nurses would do their first assessment. It would start with the typical assessment a visiting nurse would do, but it'll continue. It'll include PTSD, anxiety, and depression screening. It'll include the home safety stuff, the other usual stuff that needs to be screened. But then it's also going to include balance testing and 6-minute walk testing, which is it's a test that pulmonologists do in their office all the time. And the data actually behind it is you could track the results of that test, and it matches nicely with abilities, functional status, wellness. And of course, the hospital records are going to be reviewed. The ICU records will be reviewed by someone who works in an ICU and knows what these things actually mean. And we're looking, we're looking to make it a one-stop shop. So I've made a list of what we would be doing on our end. So once that initial assessment's done, the medical director, whether it's a pulmonologist or not, will put a treatment plan together. We will schedule all the interventions with medical providers and the non-provider staff members. We would do telehealth physical therapy and telehealth counseling and telehealth advanced directive coaching. We're going to offer telehealth healthcare proxy coaching, spiritual support. We're going to pull in something that really needs to be pulled in more aggressively is substance use support and nutritional support, nutritional counseling. Obviously things that everyone knows need to be addressed and everyone is addressing, but we're going to try to pull it in together with just one house, one location, so the patients can build trust with us and hopefully go a little deeper than others could. And we're going to focus on closed loop communication with our service, with our post-discharge clinic. I envision that in certain situations, when we form relationships with these chronically ill patients, and for me, especially if it's a pulmonary patient, I envision times when they could continue to follow up at the clinic for their pulmonary care when it's appropriate. And then they'll be sent to the office when that is necessary too. Whether or not they stay for long-term specialist care, we're going to provide reports to their PCPs throughout the program, and at the very end, when they're discharged from it, a final report of where they're at. And hopefully it'll be a nice package that when they land back with their PCP, they and or family are going to be more empowered, and the communication will be, the language will be more inclusive to what they talk about in the PCP's office. And that's the goal, right? Keep them home and at their PCPs and out of the hospital. So what would it, again, finally, what would the final thing look like? Right now, we're looking to make it a, let me just see what slide we are. Oh yeah, so, I'm sorry, I do apologize. One more change of gears here. The consultative service for the post-hospital discharge patient has been presented, but I do want to, let me swing back to this whole PICS issue, post-ICU syndrome and PICS clinic issue. On top of that, on top of the model we've already presented that we're developing, we're also going to develop more of a specific PICS clinic model on the side as well. This is going to be specifically for the ICU survivor and specifically geared towards the PICS signs and symptoms, and also specifically geared with a single endpoint of just getting a ICU survivor to re-enter their community. I'm bringing this up because the post-ICU patient obviously can be the complex, chronically ill patient with multiple comorbidities, but we sometimes forget that the ICU patient can be that, I'll give an example, I don't know, the younger patient or the patient who's been very healthy and then all of a sudden gets slammed with COVID and they've been on a vent for 2 weeks from it, and that was their only issue, and they've never had a medical problem before, and they're younger, and now that they're out, where are they going to go? Because they don't have any medical problems. They just are done from COVID. And there's really not a specific thing you could check to say, well, we're going to fix this and get you back to where you were. That's also someone who should fit into the PICS model. And getting those folks to re-enter their community and to enter society is going to be a top priority. So what would a PICS model look like that's a little different than the first model we showed? The PICS model, well, unlike the previous PICS models, I want this to be a full service solution that is unified. They face the same folks day in and day out. It'll all be in-house and efficient. There'll be no delays of coordinating, sending them to PT and nutrition, and then getting them to the cardiologist, and then back here. It'll all be one-stop shop for them. And just like with the the post-discharge transitional care model, our PICS model will have a couple, just on the next slide, a couple of more goals. We're going to screen them only with evidence-based tools, and we're going to provide a very intensive, comprehensive, and aggressive program to manage their symptoms. And what I'm talking about is visits with PT 3 times a week from home, with a therapist that they connect with maybe once or twice a week, with their spiritual leaders perhaps every day if they want to. They'll get plugged in with substance use groups, and if interested, and if everything aligns, can get plugged into programs to reduce their use of substances they shouldn't be using. And we're going to provide them with in-house equipment to further support and enhance what they're doing. And we'll give them workbooks, we'll give them pulse oximeters, we'll show them how to do their own 6-minute walk test. And if we got to get them on video every single day until they're plugged into this darn program and they're recovering from the psychological, emotional, physical disabilities that they have after critical illness, we'll do it until they're back on their feet. So last 2 slides, well, last 4 slides. Just to recap, after someone gets out of the hospital, my goal is to get them away from this, which is the DMV medical office, concept, and also these folks who can barely even get to the office. And we're going to get them from that. We're going to get them more to, again, just to show the slides again. This is what I'd rather see people doing. And that last slide, I just think that would be the nicest way to get someone who is on death's bed, down and out in an ICU. You know, to see something like this after the fact would really prove that we did our job. So that is, oh yes, of course. What would these folks, who would these folks be? I think I've already gone through it. It would be intensivists, critical care nurses, basically all the folks that have had critical care experience, like PT, therapists, nutritionists, case managers. I want them involved once the patient's outside the hospital. And again, addiction specialists, pharmacists, educational leaders, peer group support, spiritual leaders. And we're even going to, for when they do need to leave the home to get to the office for labs, et cetera, we're going to pull in medical transport personnel if we can figure that out too. So that's our model. And oh yes. Finally, you know, the first screen happens 2 weeks after discharge, but we're looking to really partner up with different hospitals in New York, get the word out. We're going to give brochures. We're going to give more talks. A lot of the red flags for someone who has PICS actually starts even before they landed in the hospital for those folks who are predisposed, and their ICU course and even what happens to them afterwards can really set them up for having this issue. So, you know, that's what I'm talking today, is just to get the word out so that we could get these things started. So that's what I got. So thank you. Thanks so much.
Great. Thanks so much for that,
Yeah.
Dr. Dinkels. I appreciate it. I know we're getting right up to time here, but I just want to check the chat here, and then we have a question. Are there plans to integrate AI into your practice?
Yeah. So yes, I'm actually talking to a colleague of mine. The AI integration, I want to focus more on equipment, not on decision-making algorithms. The equipment would be monitoring devices for the patients while they sleep. Also, some of the AI technology in the telemedicine carts themselves is something that we're looking into.
Great, thank you. Well, I want to be mindful of time
Yeah.
here. I know we're right up on 3 o'clock, but I will be sure to send out the recording notes and the slide deck to everybody that registered for the call today. I was reminded by my colleague that Dr. Dinkels did win a Telehealth Award at
Yeah.
Leadership Summit several years ago, so I wanted to flag that for this group as well.
Forgot. Yes.
Yes, thank you for that. And just a reminder that the links for the calls are at the bottom of the agenda. Our next call will be Monday, May 20th at 2 o'clock. And please, again, feel free to reach out to me with any questions, or if there's a topic that you want to see us explore on one of these calls. So thank you so much, and everyone enjoy the rest of your day.
Yeah, thank you.